Hi, I'm Sean, and I'm going to talk to you about your favorite topic, cardiac. Yay! Now, I know y'all did not know this, but your heart's a square. Well, at least at Hearst Review it is. This is the best way to understand normal blood flow through heart. So I've drawn you a pretty picture. And on the first page, you will see that we have a brief paragraph describing normal blood flow through heart. Now, we know y'all know this, but maybe someone in here needs your memory refreshed. So that's why we put it in here. So let's look at this picture together. Don't worry about writing all of this down. It's all right there in your book. Now, let's look at the diagram while we review normal blood flow through heart. The two major veins that bring blood to right side of the heart are, that's right, superior and inferior vena cava. And this blood, is it oxygenated or deoxygenated? Well, deoxygenated. This blood from venous system of the body, it enters right atrium, and then right atrium pumps it forward into right ventricle. From right ventricle, the blood is pumped forward into pulmonary artery. Hey, and this artery, does it carry oxygenated or deoxygenated blood? Deoxygenated blood. This is the only artery in the body that carries deoxygenated blood. Then this blood goes forward into lungs, where it becomes oxygenated. Then this oxygenated blood leaves the lungs through the pulmonary veins. Hey, and these veins, they carry what type of blood? Oxygenated blood. Then the blood enters left side of heart. It first goes through left atrium, which pumps the blood forward to left ventricle. Left ventricle, that's what we call the big bad pump. Now left ventricle pumps the blood forward through the first and largest artery in arterial system, which is aorta. Okay, and this oxygenated blood is delivered throughout the body through arterial system. Then eventually it ties back into venous system and blood is carried back to heart and the entire process begins again. Now the most important thing I need you to remember is this. In normal blood flow through heart, the blood only goes in one direction. What is it? Forward. Okay, so remember that, and we're going to come back to it in just a minute. Now let's talk about a few cardiac terms really fast. Here we go. Preload and afterload in a nutshell. Well, let's start with preload. Preload is the amount of blood returning to the heart. So think about that. Let's say I have somebody who's hypervolemic. They're loaded up with volume. That's a whole bunch of fluid going back to right side heart, isn't it? Yes? Okay, so what just happened to workload on heart? Increase or decrease? Increased. Now let's look at afterload. Afterload is the pressure in aorta and peripheral arteries that the left ventricle has to pump against to get blood out. This pressure is often referred to as resistance. In other words, how much resistance the left ventricle has to overcome to get blood out. Yes, out of ventricle and out to the body. Now underline peripheral arteries because that's what causes the most resistance. The left ventricle, its whole life, it's working hard to pump against this resistance. That's the reason left side of heart is always thicker and more muscular. But if I had the high blood pressure, that's even more resistance left ventricle has to pump against. That's why high blood pressure can eventually lead to heart failure, pulmonary edema, because this high afterload decreases your cardiac output. It decreases forward flow. Plus it wears out your heart muscle. Now we're going to keep using these terms throughout the lecture. One other thing we're going to talk about is stroke volume. Stroke volume is the amount of blood pumped out of the ventricles with each heartbeat. Now let's look at cardiac output. And you can see there's a formula on your handout. Cardiac output equals heart rate times stroke volume. You know this cardiac output, it can be calculated using fancy catheters, monitors. Hey, but I'm a brand new nurse with how many weeks of experience? 2 weeks of vast nursing knowledge. Do you think the NCLEX lady expects me to know a whole bunch about calculating hemodynamic parameters? No. Thank goodness for that. Hey, but NCLEX lady does expect me to understand the things that affect my cardiac output. So let's look at your book. First of all, the book says tissue perfusion is dependent on adequate cardiac output. And cardiac output changes according to your body's needs. As you sit here in class, are you requiring an increased cardiac output? No. What if you were running late this morning and you had to hurry up to get there? Okay, your requirements just went up. So your body adjusts by increasing what? Heart rate and stroke volume, which makes your cardiac output go up. Now before we go any further, let's talk about cardiac output and the things that can affect it. Factors that affect cardiac output. Heart rate and certain arrhythmias can affect somebody's cardiac output. So let's pretend you're taking care of a patient one night and the heart rate drops to 32. What just happened to your cardiac output? Decreased. So could bradycardia be a cause of a decreased cardiac output? Why, yes. Now this is not on the handout. I'm just talking here. What if my heart rate jumps up to greater than 200 beats per minute? Oh, sure. You could get fancy and call it something like paroxysmal supraventricular tachycardia. Hey, I don't care. If my heart rate is beating this fast, if my ventricles are beating this fast, do my ventricles have time to fill with blood? No. So cardiac output just went down. So we all agree, if the heart is beating too fast or too slow, my cardiac output can be affected. What about blood volume? If I have a decreased blood volume, say from surgery, or maybe I have been severely burned, what happens to my cardiac output? Increase or decrease? Decreased. Why? Less volume. The last thing I want to talk about is decreased contractility, or the things that affect the muscle contraction. Here I'm talking about MI people who've had myocardial infarctions, certain medications, and muscle disease. So let's go to the top of the next page in your book, and I want you to write something down. I want you to write left ventricle equals cardiac output. Left ventricle equals cardiac output. From this point forward, whenever I'm talking about cardiac output, I need you to think left ventricle. That's why I had you write it at the top of the page. Okay, so let's look at the picture of the square heart. See, the left ventricle, if it's not pumping good, you know blood's going to back up into lungs. But are there other effects a decreased cardiac output can have on the body? Yes, because remember, the left ventricle is supposed to shoot the blood in what direction? Forward. For what purpose? To perfuse my body. We hope at least to perfuse my vital organs. Now, let's look at the patho of a decreased cardiac output. If your cardiac output is decreased, will you perfuse your body properly? No. Will you perfuse your brain real well? No. So your LOC is going to go down, decreased. Are you going to perfuse your heart real well? No. So your client may start complaining of chest pain. How are my lungs going to sound? Wet. Okay. Could I be short of breath? Yes. If your cardiac output is decreased, are you going to be perfusing your skin real well? No. So how is your skin going to feel? Cold and clammy. Am I going to perfuse my kidneys real well? No. So we know urine output is going to go down, decreased. Hey, what's going to happen to peripheral pulses? Weaker or stronger? Weaker, that's right. Less volume, less pressure. So the heart is weak. It does not pump out blood like it should. So peripheral pulses are weaker. Now let's do a critical thinking exercise. All right, let's pretend you're taking care of a client one night and they've been in a sinus rhythm. Everything is just great. They're awake, alert. The lungs are clear. They're not short of breath. No chest pain. Vitals are stable. They have a good urine output. The skin is warm and dry. Strong peripheral pulses. Then 3 a.m., they switch to the bradycardia. Now that arrhythmia, it's no big deal as long as they still have a good cardiac output, right? Okay, well let me tell you something. Arrhythmias are no big deal as long as I still have a good cardiac output. You know, when people are in pulsus, V-tach, V-fib, and asystole, what's my cardiac output? None. Hey, that's why they're a big deal. So you see, that's what goes in your blanks. Write that down. Pulseless V-tach, V-fib, and asystole. No cardiac output. You're dead, dead, dead unless they do something to bring you back. That's why they're a big deal. Okay, so let's say I switch to the bradycardia. Do I still have a cardiac output? Yes. But some people can tolerate it more than others. Some people can tolerate the rhythm change and some cannot. So how can I tell if my patient is tolerating the rhythm change? What should I go assess? Well, cardiac output, since we're on the cardiac output page, so here we go. Your client just switched from sinus rhythm into bradycardia. I know that's not a life-threatening arrhythmia, but I know that some people can handle it and some cannot. So I go into the room to assess my client to see if they're tolerating it. Tell your friend everything you're going to assess on the client to determine if they're tolerating the change in the rhythm. Now, you don't have to write all this down. We just went over it. But you're going to go in and check their LOC. You're going to listen to their lungs. You're going to ask them, are you short of breath? Are you having any chest pain? Feel their skin. Is their skin warm and dry? What are their vital signs? What is their urine output been? If all that stuff's great, are they tolerating the change in the rhythm? Why, yes. My point is this. Anytime you have to call a doctor about a change in the rhythm, you can't just say, hey, your patient, their rhythm changed. Thought you should know. Okay, bye-bye. No, this stuff we just went over. Tell them ahead of time. They need to know that you know how to assess their cardiac output. They don't care about pupillary reactions right now, bowel sounds, hand grips. No, they want to know that you know how to assess for a good cardiac output. So go ahead and tell them up front before they start asking about it. Okay, let's move on. Let's look at chronic stable angina. Let's look at the patho together. This is decreased blood flow to the myocardium, which leads to ischemia or necrosis. Ischemia. Ischemia is what you need to write down. And the ischemia can lead to temporary pressure, pain in the chest, usually caused by CAD, coronary artery disease. Now, what brings on the pain? Low oxygen, usually due to exertion. You see, it's the exertion that brings on the low oxygen. What relieves the pain? I want two answers. Rest or nitroglycerin? Treatment. Well, medications are first. Nitroglycerin. Well, I'm talking about sublingual again here. It causes venous and arterial dilation. This is a good thing because this will cause decreased preload and afterload. Well, good, because when you decrease preload and afterload, this decreases workload on heart. Decreases the workload on the heart. That's key. You never want to increase the workload on heart people, do you? No. Okay, anytime you've got a heart person, we have to decrease the workload on the heart any way you can. Nitro also causes dilation of what? Coronary arteries. Yes, which will increase blood flow to actual heart muscle, the myocardium. Well, that's a good thing because the increased blood flow to actual heart muscle, well, what's this blood carrying with it? Oxygen. And my heart says, thank you, that's what I needed. Now then, take one every 5 minutes times 3 doses. It's okay. Is it okay to swallow your nitro? No, it's sublingual, isn't it? It should be. The nitro should be kept in a dark glass bottle. Don't mix the medication in the bottle, anything else in the bottle of nitro. Okay? And do not open the bottle frequently. Keep it dry, keep it cool. It may or may not burn or fizz in the patient's mouth. Some brands of nitro will burn when you place them under the tongue. That's okay. That's normal. And the client will get a what? Headache. They're going to get the headache. Should you call the doctor? No, we're not going to call the doctor about that. We expect that to occur. That's not life-threatening. Now, how often should nitro be renewed? An average, every 3 to 5 months. Average, 3 to 5 months. 2 years for the spray. Okay, and after nitro, what do you expect the blood pressure to do? Drop. I expect it to drop because it's vasodilating me all over. But you can't look at that and say, hey, that's okay. It's normal for blood pressure to drop. I expect that to happen. No big deal. Nitro does that to you. Rule, never leave an unstable client. Okay? When you're manipulating somebody's blood pressure, they're unstable. Okay? Yes, we know their blood pressure is going to drop, but I expect it to come back up. The problem is the blood pressure could keep going down. So we're not even going to leave them till they have stabilized. And that's how they're going to get you on a test question. They're going to give you something normal like hypotension with a nitro. And you're going to think to yourself, oh, don't worry about that. That's supposed to happen when they take the nitro. It's okay. I'll be back in a minute to check on you. No, you never leave an unstable client. Okay, beta blockers are next. We have several listed for you on your handout. Well, what do beta blockers do to blood pressure, pulse, and myocardial contractility? Decrease it. That's why we always check the heart rate and blood pressure before we give the beta blockers, because beta blockers slow the heart rate and reduce contractility. This goes for any time you're giving a client an antihypertensive medication. We're checking the blood pressure. So what do beta blockers do to workload on heart? Decrease it. Even if you did not know the answer, I know y'all would never do anything with the angina client to increase the workload on the heart, like increasing their heart rate and blood pressure. Let's look at your book, and y'all read with me. Beta blockers block the beta cells. These are the receptor sites for the catecholamines, epi and norepi. So we just decreased contractility. So what happened to my cardiac output? Decreased. So we decreased workload on my heart. Well, this is a good thing to a certain point because we decrease workload on the heart. But could we decrease the client's cardiac output, heart rate, and blood pressure too much with these drugs? Why, yes, that's what I'm scared of. So I'm watching for it. Now, calcium channel blockers are next. Again, we have some listed for you on your handout. Well, what do you think these drugs do to your blood pressure? Decrease? We're not going to pump up the blood pressure now, are we? Never on a heart client. No, that would be mean. Put a big star by the next statement because that's the primary reason we give these drugs to people who have the angina. They also dilate coronary arteries. They dilate the coronary arteries. Well, that's a good thing because now more oxygen is going to get to heart muscle. Now, aspirin is listed next. This is also given to a client having angina to keep the platelets from sticking together in case the client is actually having the MI. A chewable aspirin is best because it will start working fast and stop the clot from forming. The dose depends on what the physician prescribes. It can vary 81 milligrams to 325 milligrams. Now let's look at client education for chronic stable angina. It says avoid isometric exercises. These are the exercises where I think about tensing up, squeezing your muscles, tensing up. What will this do to workload on heart? Increase workload on heart. You know we never ever ever increase workload on heart people. No. Now, I know I've had people come up to me and say, I know somebody who had unstable angina and they had the MI and now they're a weightlifter. Okay, that's great, but do not pick it on the test. Don't pick weightlifting as the client's new hobby. We're just trying to pass the test. Okay, avoid overeating, rest frequently, avoid excess caffeine or any drugs that increase heart rate. Wait 2 hours after eating to exercise. Dress warmly in cold weather. Y'all, we're doing everything we can to decrease workload on heart. Decreasing the workload on the heart. I just said dress warmly in the cold weather. Any temperature extreme can precipitate an attack. Y'all, what about the hot weather? Can that precipitate an attack? Why, yes. Okay, so what if you had an angina client and they went out and ordered them a big, tall, frozen daiquiri and they drank it really, really fast? Could that precipitate an attack? Yes. And then it says, take nitroglycerin prophylactically. Now, when you take your nitro, how are you going to feel? I'm standing here and I take a nitroglycerin, pop it under my tongue. How am I going to feel? Dizzy. Because what's happening to my blood pressure? Dropping, decreasing. So you better sit down and take your nitro. That's a safety thing. Teach smoking cessation. They're going to tell the angina people to lose weight. Okay, next, let's talk about cardiac catheterization. Pre-procedure, we want to make sure or ask the client, are you allergic to what? Yes, iodine, shellfish. Iodine, shellfish. Also, we have to check their kidney function because we know the dye is excreted through the kidneys. If the client has poor kidney function and they receive this dye, could it cause renal failure? Yes. You know, and many doctors, they'll order this medicine called Mucomyst, acetylcysteine, pre-procedure, especially if they have some kidney problems, because this will help protect the kidneys. They're going to get something called the hot shot, and they'll warn them ahead of time, and that's when they're injecting the dye. Anytime we give an iodine-based dye, when we're giving this to someone, they're going to feel the flushing and warmth. Even if your client, let's say they're having a CT with contrast, they're going to have the flushing and warmth. So should you tell them ahead of time? Yes. And palpitations are normal too. Post-procedure, we're monitoring the vital signs. We're watching the puncture site. What are we watching this for? The puncture site? We're watching it for bleeding or hematoma formation. So we're checking the groin for hematoma. So we palpate around the puncture site. We assess the extremity distal to the puncture site. All right, what are we assessing for? Ask your friend all the things you're going to check for this patient. We're assessing the extremity distal to the puncture site. So tell the person sitting next to you, what are all the things you're going to assess? Well, it says on your paper, the 5 P's, pulselessness, pallor, pain, paresthesias, and paralysis. Now don't forget, skin color, skin temp, and capillary refill. In other words, we're checking circulation. Hey, should have we done a baseline assessment on these people? Why, yes, before they went to the heart cath, we should have done a baseline assessment. We might have even marked the pulses where they were. We got to make sure the pulses are the same as baseline. And then when they come back, we're going to be checking the pulses frequently, especially in the first hour. Well, they're going to be on bed rest. We keep them flat. We keep their leg, or well, maybe they went through the arm. No matter where the insertion site is, we have to keep that extremity straight. It needs to stay straight and flat for 4 to 6 hours. The exact time depends on the doctor's order and the medications that the client received. Now I know there's some new things out there, VasoSeal, AngioSeals, Duets, closure pads, all these things, but I'm a brand new nurse. And the number one thing that you're supposed to worry about with the heart cath is hemorrhage. That should be the first complication that pops into your mind. Now, we want the client to report any pain as soon as possible. If they have pain at the puncture site, then a hematoma might be forming. They might be bleeding. And again, the major complication post-cath is bleeding. One more thing before we move on that I need to mention. These people, if the client is on glucophage, metformin, the MD will write an order to hold the medicine before they go to heart cath and then hold it for 48 hours post-procedure. Why? Again, we're worried about the kidneys. Okay, let me say one more thing before we move on. One more thing about angina. Normally people with angina, stable angina, they know what brings on the pain and they know exactly what relieves the pain. But could I get to where I no longer can predict what's going to bring on the pain and what I used to do no longer relieves the pain? Yes? Well, then I have the unstable angina, and if this gets bad enough, what am I headed for? An MI. I could just go ahead and have the MI. So that's what I want to talk about next. Acute coronary syndromes. This includes MI people and unstable angina people. So let's look at the patho. This is decreased blood flow to the myocardium, which leads to ischemia, necrosis, or both. Both. Here we have ischemia and necrosis. One of our major objectives with the MI people is to limit the size of the infarction. In other words, if you got to have a heart attack, what kind do you want? Teeny tiny one. Because remember, dead tissue does not pump well. So we want to limit the size of the infarction. Does the client have to be doing anything to bring on this pain? No. They may be asleep. I bet your teacher told you a lot of the MIs occur in the early morning hours. That's when the client is in the REM sleep. Your heart rate increases, your blood pressure goes up. You're having all those wild dreams you can't remember 5 minutes after you wake up. You know the ones I'm talking about, the ones where you're fighting the bad guys. And you look across the field and there's your hero. So what just happened to workload on heart? Increased workload on heart. Could I go ahead and have a heart attack? Why, yes. Hey, will rest or nitro relieve this pain? No. Signs and symptoms are next. The client may describe the pain as crushing. An elephant is sitting on my chest. Pressure. Can it radiate down my left arm? Yes. Can it radiate to my left jaw? Yes. Nausea, vomiting. Can they have pain between the shoulders? Yes. But nobody ever presents like the textbook now, do they? Especially women, diabetic people, or elderly people. You know, I've seen a client having an MI, and all they were complaining about was a little bit of jaw pain. Y'all, we know this. You must assume the worst about every single thing. Now, I just said a minute ago, women, diabetics, and elderly. I want to talk about that a second. Women usually present with GI signs and symptoms, epigastric complaints or pain between the shoulders, aching jaw, maybe choking sensation. Some books say women have a triad of symptoms. So here we go. Indigestion or a feeling of fullness in the abdomen, chronic fatigue or inability to catch one's breath. And the diabetic people, they have neuropathies, so they may not sense the severity of the pain. And also the elderly people, the older somebody gets, they may present with less pain or no pain at all, okay? The older you are, the less you'll present with MIs, like the book says. Elderly people, hey, when they're having the MI, they might just faint. Hey, but the number one sign for elderly people is shortness of breath. Another thing is this. With elderly people, I need you to remember behavioral changes. Elderly people are likely to have behavioral changes when they're in pain. Okay, let's pretend you have a little lady at the nursing home, and she sits in her wheelchair with her Afghan on and her pink fuzzy slippers. And she's so sweet and so nice. And one day you walk by her and she curses at you. Are you going to be like, oh, poor Granny, she's getting worse? No, y'all, I want you to assume the worst. Okay, she may be having something simple like a UTI, but you can't just say, Granny, oh, she's getting worse. She's talking ugly now. On the test, we have to assume the worst. Something's going on. Okay, we've got to rule out the life-threatening possibilities first. Then we'll look at UTI. Now let's look at the next group of symptoms. Cold, clammy, blood pressure's dropping. I know the cardiac output is going down, decreasing. I know cardiac output's decreasing because dead tissue does not pump well, does it? No. And the white count is going up. Your temperature is going up, increasing. Both of those will increase due to inflammation. Okay, they're going to have a low-grade temp for a few days. They're not going to spike the high temp. Now then, EKG changes are next. Is your heart irritated? Yes. So we're going to have some of these EKG changes. Notice in your book, it says STEMI and non-STEMI EKG changes. You may see those terms on the test, or your patient could have other changes, maybe an arrhythmia, or they could go all the way to pulseless V-tach, V-fib, and asystole. Maybe just a lot of PVCs. It just depends. You see, when they're having the heart attack, the heart is irritable. There's hypoxia in the heart. That's what causes the EKG changes. Vomiting is next. Can our client vomit? Yes. There's two reasons why this client may vomit. The first reason is acute pain. It stimulates the vomiting center in the brain. Okay, when people vomit, what nerve is stimulated? Vagus. And when you stimulate the vagus nerve, what happens to the heart rate? Increase or decrease? Decrease. So what happens to my cardiac output? Decreased. So what just happened to the blood pressure? Decreased. Could it get worse? Yes. Another reason is this: vasovagal reflex. The vasovagal reflex from the area of the MI may also affect the GI tract, leading to the nausea. Now let's look at some diagnostic lab work. Well, it says on your handout, CPK-MB, troponin, myoglobin. Let's look at CPK-MB first. Okay, this is a cardiac-specific isoenzyme. This will be increased if there's damage to the cardiac cells. And CPK-MB will be elevated within 3 to 12 hours after the onset of symptoms, and peaks in 24 hours. Peaks in 24 hours. Now let's look at troponin. Well, it says on the handout, it is a cardiac biomarker. It is most specific to myocardial damage. There are two specific isomers called troponin T and troponin I. It also says that troponin elevates within 3 to 4 hours after the onset of chest pain and remains elevated for up to 3 weeks. Troponin levels are only affected when there's heart muscle damage. Now, let's look at the last biomarker, myoglobin. The myoglobin level starts to increase within 1 hour and peaks in 12 hours. Peaks in 12 hours after the onset of symptoms. This marker, it's not very specific to diagnose an acute cardiac syndrome, but if it's negative, it's an excellent way to rule out a myocardial infarction. So negative results on the myoglobin, this is a good thing. That's the good news. Okay, which cardiac biomarker is most sensitive? Which is the most sensitive indicator of an MI? Troponin. Troponin is the most sensitive and most specific in detecting cardiac muscle damage. That's the one that means heart muscle is damaged. Now, which enzymes or markers are most helpful when the client delays seeking care? Troponin. That's what I want you to pick, troponin. Now let's look at complications. Let's talk about major arrhythmias. What untreated arrhythmia will put the client at risk for sudden death? Ventricular fibrillation. Ventricular fibrillation. That's the major arrhythmia I'm worried about, VFib. Because when you're in the VFib, what's your cardiac output? 0. You see, the heart, it's irritated. It's hypoxic. Now, when somebody goes into the VFib, what do we want to do for them? Defib. That's the only treatment for VFib. You need to be doing the CPR, okay, until you get an effective heartbeat. But in between the defibs, we're doing CPR, but the only treatment for VFib is defib. Defib the VFib as soon as possible, because the longer we wait, the less likely it's going to work and bring the client out of the VFib. Remember, pulseless VTach and asystole, they can also occur and result in sudden cardiac death. But the take-home message is this: don't delay defibbing the VFib. And you know, that's why we have all the AEDs in public places. So we hurry up and defib the VFib. One thing I need to mention is this. In a code situation, if after the first shock, the defibrillation, if that doesn't work and the client remains in VFib, what's the first vasopressor that we're going to give this person? Epinephrine. Epinephrine is the answer. We're trying to get something started. Hey, if that doesn't work, then we might give amiodarone. Amiodarone is the next thing on your handout. Amiodarone is an antiarrhythmic. It's used when the V-fib is resistant to treatment. It's also used sometimes to treat fast arrhythmias. Okay, but I need you to remember, amiodarone is an antiarrhythmic medication, not a vasopressor like epinephrine. Now, what antiarrhythmic drugs are commonly given to prevent a second episode of V-fib? Well, lidocaine and amiodarone. Amiodarone we just talked about, okay? It is the first antiarrhythmic of choice. Some doctors still pick the lidocaine. It just depends on where you work. Let's talk about lidocaine for just a second. When I think about lidocaine, I think about numbing somebody up. Anytime you have a medication that's a cane, it numbs you up, doesn't it? Like Novocaine, lidocaine, these things. Okay, lidocaine decreases the irritability in the heart. It makes you stop throwing those PVCs. Now, what is a sign of toxicity with this medication? Okay, I just gave you a hint. It numbs you up. So what's another system that could be affected? Well, central nervous system. So I want you to write down any neuro changes. Any neuro changes. So if somebody's had too much lidocaine, think neuro changes. What's an important side effect I need you to remember with the amiodarone? Hypotension. Hypotension. Blood pressure drops. What are you worried about with other arrhythmias? Well, hypotension. Blood pressure dropping. Could get worse. It could drop out the bottom. Could it go all the way to asystole? Yes. Okay, next I want to look at treatment. What are the drugs used for chest pain when they get to the emergency department? Here's what you want to write down. Oxygen. Oxygen. Aspirin. If they have not gotten it before they got to the hospital, we're going to give them some aspirin, 165 to 325 milligrams. Hey, would you rather give them a tablet or chewable aspirin? Chewable, because it works faster. Now, this aspirin is given to prevent platelet aggregation, not because it's a pain reliever, no. Okay. The next medicine, nitroglycerin. I know we all know that one. And last, morphine. Morphine. If the pain is not relieved by the nitro, we're going to give the morphine. And in that order. Okay, the next thing it says on your handout, head up position. Why? If you have this client having the myocardial infarction, don't lay them flat. That's mean. We have to sit them up to decrease workload on heart. To decrease workload on heart and increase cardiac output. Now let's talk about fibrinolytic therapy. I bet your teacher told you door to drug time, 30 minutes. That's the goal. Now, if you work at a place, though, that does interventional cardiology, these people, if you work there, that's the gold standard. They'd rather get them into the cath lab than give the fibrinolytic. Okay, that's the treatment of choice. But if you live in a rural area, you might get fibrinolytic. Well, let's talk about it. It says on your handout, the goal is to dissolve the clot that's blocking blood flow to heart muscle. We want to decrease the size of the infarction because remember I said when you're having the heart attack, you want to have a teeny tiny one. So we hurry up. What we want to do is hurry up and restore blood flow. That's what we're trying to do here. Now on your handout, we've listed some fibrinolytics for you. Streptokinase, TPA, TNKase, that's a one-time IV push, Retivase. There's others that can be used too. But out of those, which one do people tend to have allergic response? Streptokinase. Streptokinase is the one that they tend to have allergies with. Okay? They still give it to them, but they're going to treat them for the allergy. How often, after the onset of pain, should these drugs be administered? Within 6 to 8 hours. Within 6 to 8 hours. The sooner the better, right? Now there's some studies out there that say as long as you give it, as long as you administer it, within 12 hours, we're still doing real well with this person. Now y'all, if I were having a brain attack and we're going to give a fibrinolytic for a stroke client, the window is much smaller. Just remember, time is brain when I'm having the brain attack. All right? Hey, what's the major complication of fibrinolytic? Bleeding. That's what I'm scared of. Bleeding, hemorrhaging. So we have to get a good bleeding history. What kind of history? A good bleeding history. Okay, so we've got to ask them some questions about blood or bleeding. So we're going to ask them, have you had any recent surgeries? Recent stroke? Bleeding ulcers? These things. Even pregnancy, we ask them that question. Those are the things we're worried about. Hey, right now, I'm not really interested. Is your mama a diabetic? Right now, that's not pertinent, okay? We have to ask them questions related to the bleeding. Okay, and then we have some times when you do not give fibrinolytic, and they're listed there for you. The absolute contraindications: intracranial neoplasm, intracranial bleed, suspected aortic dissection, and internal bleeding. Now, during and after administration, what kind of precautions are we going to take? Bleeding. We're going to take bleeding precautions. Now, when I say bleeding precautions, it's the same principles as if you have somebody on heparin, Coumadin, Lovenox, Integralin, ReoPro, all those medicines. And below we have listed for you other times when we're taking bleeding precautions. So I think about somebody we take bleeding precautions on, maybe somebody who has liver disease, alcoholic people, or anybody who's overdosed on the Tylenol. You know, Tylenol kills the liver. Kills the liver. We need to draw blood when starting the IVs because we're trying to decrease the number of puncture sites. Decreased number of puncture sites. Now another thing is this. You wouldn't want to draw an ABG on this person, would you? No, because it's an artery, so they're going to bleed. I know in the real world you might see somebody who got the TPA get an ABG, but don't pick it on the test. That's a high-risk procedure. Antiplatelets are another important component of fibrinolytic therapy, and they're listed for you: aspirin, Plavix, ReoPro. Next, I want to do a critical thinking exercise. Are you ready? Let's pretend you're working in the emergency department and you have a client coming in. They're having the heart attack. They're having an MI. And this client does not have IV access. And you know the doctor is going to want to give TPA. Do you want a peripheral line or central jugular line? Discuss that with your friend. Okay, everybody, let's vote. Who went for peripheral line? Okay. Who went for the central line? Okay, now everybody listen with me. What is the major complication with the fibrinolytic? Hemorrhage. Okay, so for those of you who went with the jugular central line, when it starts bleeding from this site, when anything starts bleeding, what are you supposed to do? Hold pressure. Okay, I promise, if you're holding pressure on your patient like this, you're going to get fired. No, we have to pick large bore peripheral sites. Compressible sites is the answer. Compressible sites with the fibrinolytics. Okay, let's move on and look at medical interventions next. PCI, which stands for percutaneous coronary intervention. This includes all interventions such as PTCA, that's your angioplasty, and stents. Now tell your friend, what are they trying to do with the balloon or the stents? What are they doing for these people? They're trying to open up the artery, open the coronary artery to restore blood flow to heart muscle. Open up coronary artery to restore blood flow to heart muscle. And you know, this angioplasty, it can be done on any artery in the body, not just with the heart. It can be done, they can put the stents in renal arteries, carotid arteries. Now, what's a major complication I need you to remember with the angioplasty? Myocardial infarction. MI, they could just go ahead and have a heart attack during the procedure. Now, don't forget, the client may bleed from the heart cath site as well. So we're watching the heart cath site. If any problems occur during the procedure, they're going to go to surgery. They need to go to surgery. You know, this is what happened to Mr. Letterman, David Letterman. They were doing the heart cath. He was on the table, but he started having an MI. So he went to surgery. And guess what? He had CABG times 5. If your client has any chest pain after the procedure, you need to call the doctor as soon as possible because the client is most likely reoccluding the vessel and needs to go back to the cath lab. These clients will also be placed on antiplatelet medications that we mentioned earlier, like aspirin, Plavix, ReoPro, Integralin, those medicines. Now, ReoPro and Integralin, they're given to high-risk clients who've been stented to keep the artery open, or high-risk clients who are waiting to go to the cath lab to keep the clot from getting bigger. Okay, coronary artery bypass surgery is next. Some people just call it CABG for short. It's another name for open heart surgery. It may be scheduled or it could be emergency. Okay, the client will go for a CABG if they have multiple vessel disease or if their left artery, their left main artery to the heart is occluded. Left main artery is occluded. Okay, because we know the left main artery supplies entire left ventricle. Okay, if that artery is occluded, sudden death can occur. That's why with that particular type of clot, we call it the widowmaker. Now, clients going to have to go through the rehab plan, smoking cessation. They're all going to have a stepped plan where they can increase their activity gradually, a little bit at a time. Diet changes are next. What are they going to do with their fat? Low fat, low salt, low cholesterol. Okay, they really don't want these people eating the fried foods. Well, at most, once a month. Once a month for enjoyment. Hey, and they tell them at the grocery store they're supposed to shop the perimeter. Shop the perimeter. Why? What's in the center of the grocery store? Little Debbie snack cakes. All the really good stuff. What's high in sodium, fat, trans fatty foods. See, the fruits and veggies are perimeter. So we tell them, shop the perimeter. No isometric exercises. Again, we're saying this. When I think about the isometrics, I think about these people squeezing up, tensing up. We don't want to do that because what do isometrics do to workload on heart? Increase workload on heart. And that's bad for heart people. No Valsalva. That's bad, bad, bad. Okay, why? The Valsalva is bad for heart people. The vagus nerve, it's hyperexcitable. It's ready to be stimulated, so don't touch it, especially for the heart people, because what's it going to do to their heart rate? Decrease. Could it go all the way to asystole? Why, yes. No straining, no suppositories. The clients need to be on Colace. When can sex be resumed? Hey, this is a major concern for the heart client because they think that when they're having sex, their heart rate's going to go up, their blood pressure's going to go up so much that they might have another MI. Hey, that's not going to happen. The workload on the heart does not increase that much. Sex can be resumed when they can walk around the block or up a flight of stairs with no discomfort. Do y'all remember the movie Something's Gotta Give with Jack Nicholson? Y'all remember that? And he kept looking at the stairs, shaking his head. Now the next question says, what is the safest time of day for sex? Well, in the morning, when the client is well rested. Now I know in your head you're thinking, but you just said that's when they're most likely to have the MI. Okay, well be sure and counsel your people. Do not have sex during REM sleep. Okay, I'm just saying, 8-ish or 9-ish, that would be okay. Okay, what is the best exercise for the MI client? Walking. I heard one of y'all say sex. No, walking. Teach the signs and symptoms of heart failure. Y'all, see, if I have the heart attack, is there a chance I could go into heart failure? In 2 weeks, maybe 2 years from now, so we've got to teach it. My heart is in a weakened state now. So here we go. Things like weight gain, ankle edema, shortness of breath, and confusion.